And at that point in time, it came to know that we had a coronavirus. We call it SARS-CoV-1. At that time, we called it SARS-CoV coronavirus, but now we call it 1 because we have something called coronavirus 2, and that's basically COVID-19. Then I go back a bit. We went in Jeddah in 2012. We had another coronavirus epidemic, and it was called as MERS coronavirus, Middle East Respiratory Syndrome. But the one we have now, which has established since December of 2019 and came from Wuhan, China, is the most intricate, difficult to understand, and has taken the maximum toll, and is the only pandemic from the corona groups. So what causes COVID-19 is basically SARS-CoV-2. So it's the same SARS-1, but it's SARS-2, and we call it novel coronavirus. The word novel stands for it's a new virus. A lot of people trying to find out ins and outs of the virus, but at this minute, we're still teething trouble to understand what it is all about. Yes, Mr. Ibrahim.
Yeah. Having said this, may I go to the next question, mostly for the medical students. What are the symptoms of this disease? How are they different from usual flu?
I think, again, not only for the medical fraternity who is listening to, I think it's also for the layman. I would say 90% of the patients of SARS-2 or COVID-19 will have basically mild symptomatology. Now, to put it in context, I would say 80% will have symptoms which are so mild that they may not even recognize those symptoms, i.e., they could have simple like the common flu. They can have headaches, they can have fever, they can have running nose, they can have shivering, they may have feeling tired. I think this is one of the most important symptoms we have to know is feeling tired. In fact, the studies have shown fever may not be the most common symptom to start with, but feeling tired is a very common symptom. Then we also found patients could have diarrheas. A new onset diarrhea can be a symptom of COVID-19. To add to the group, we also found some patients even had a lot of smell. The medical term for it is anosmia. And some have found there's no taste for the food, so loss of taste of the food. And also the list is a big list, and I would want to make a mention of some new things which we have found throughout the world, especially they came in being in the Europe, was patients starting developing more strokes, transient ischemic attacks, TIAs. Even coronary events have happened which have been related to COVID-19. And in children in the UK, they found a series of symptomatology which was conforming to basically a vascular syndrome like Kawasaki's. So I've given you a wide range of symptomatology. I don't want to confuse all of you, but what I want to tell you is that 80% patients will have benign symptoms. They could have a fever of a day. They could have cough, a mild dry cough, and that's it. They had their quota of COVID-19, so to say. But yes, 10 to 15% patients may have more protracted symptoms. They will have a cough, which is nagging cough. They may have shortness of breath. And that is what gets them to the hospitals most often than not. Yes, Dr. Ibrahim.
Yeah. So what's your UK experience? Suppose a patient is at home and has symptoms suggestive of corona. How does he go about it?
All right. I think it's a very practical question, a very important question you have asked me. Well, in the UK, we are totally different than what you have been doing in back home in India. In the UK, if we are not key workers, now I will define a key worker. A key worker is a doctor, a nurse, hospital porter, dispenser, pharmacist, or it could be the people who are dealing with the delivery of your drugs, NGOs, social workers, health workers. They're all called key workers. Now, for these key workers, if they are not well, in other words, if they start symptoms suggestive of COVID-19, they will have to be screened for COVID-19 test. Other than that, people who are not falling in this category will be asked to stay at home the way people are at home in most of the world. So if I'm a person, I'm not a key worker, say for example, I'm an architect by my profession, I'm at home. We in the UK have what we call is a COVID-19 helpline. There's a telephone service, also on the net. If I'm not having, if I start developing symptoms which to me look like COVID, for example, I have a fever, I will call the helpline, and the helpline is organized by medical experts who have the knowledge about how severe the COVID in this patient is. So they will ask a questionnaire, which will be comprised of 1, 2, 3, 4, and then they will quickly analyze the severity of this patient's symptoms. And if in their opinion, they feel this patient is stable enough, they will tell him, listen, my dear, stay home. Stay home. You do not move out of your house until you're okay for 7 days. So this is a common way we tackle patients. Now, at this time, if there's another patient who gives his symptomatology onto this helpline and his symptoms are difficult, i.e., he's feeling short of breath, he's not able to cope, then he will have to call the ambulance service. The ambulance will come to his doorstep, will take him from there, drop him in the hospital, and then his journey starts from the hospital onwards. Is that clear, Dr. Ibrahim?
Yes, sir. Yes, sir. Thank you so much for this explanation. Now, we have seen around 2 lakh people have died world over. So who are at risk of dying from this COVID infection? Can we know this from the history?
Oh, yes, absolutely. First of all, we have to understand, older we are, worse we are. Younger we are, better we are. Now, when I say younger we are, better we are, it does not mean the young are exempt from getting COVID-19. But once they get it, invariably, it won't be a severe one. On the contrary, if you are about 60, 65, 70, 80, 90, then the corona or the COVID infection in these population tends to get more severe. So this is one is the age. The second is underlying medical conditions. For all the studies which have been done worldwide, they found 3 conditions standing very prominent. And they were, number 1 was hypertension. If somebody has a high blood pressure or hypertension, or somebody has type 2 diabetes, means diabetes in elderly, and if somebody has a history of a heart illness, mostly ischemic heart disease, these 3 medical conditions, by and large, worldwide, have really shown that if somebody has one of them, 2 of them, and all of them, then they are a bit high risk for the way they will behave when they will get COVID-19. Well, having said that, I will also add one more thing which came later on and is basically linked to all the 3 symptoms, all the 3 diseases, is increase in the body weight or obesity. Now, obesity has been a very important factor we found in mortality of COVID-19. Well, it's not a rocket science. If you people know of people who have passed away and you have their photograph, most often than not, you will see their photograph tells you that their weight was on the higher side. Dr. Ibrahim.
Okay. So we come to the next question. How do you go about COVID infection in your trust, NHS?
Now, could you elucidate your question, please?
Just I want to know what's your policy in managing these patients.
All right.
How do you triage them? How do you take them to the...
So let me not go back to where I said. So let me just start from basically from the previous thread. Now, having ascertained that a patient has called the COVID-19 services and is poorly, is not doing fine, and the services have rendered him high risk, they will call an ambulance and he comes to the hospital. Now, once he's in the hospital, he'll be quickly triaged. Now, triaged means this is the early most assessment done quickly to look at eyeballing the patient. A, how is the patient feeling in himself or herself? Is the patient breathless? Can the patient make a sentence? What are his vitals like? What is the blood pressure doing? What is the heart rate doing? What is his respiratory rate doing? And most importantly, how much is his oxygen on ambient air or room air? Now, at this point in time, the patient is screened for COVID-19. So I reiterate, any patient in the UK who has the problems enough to come to, am I on the line? Because I thought I've been lost.
No. You're on the line. Somebody, somebody has by mistake put it.
Yeah. All right, nobody. I think I'm off air and I'm just talking to nobody.
Yeah. Yes. You're on the line.
All right. So when this patient has been screened, now we will wait for the test. Now, once the test has come as positive, he'll be put in the red ward. Now, in your country, in my country back home in India and Kashmir, you have made the red zones, the green zones, and orange zones on the streets, but we make those zones in the wards. So a red ward for me would be a ward which is COVID positive ward. So this patient, if he tests positive for the screen, he is automatically going to the COVID ward. And on the ward, primarily, we'll have to assess this patient clinically, i.e., we'll examine him, we'll get his bloods done, and get his chest X-ray done. And I must admit at this point in time, there's no role of CT scan to be done at the drop of the hat. We don't need a CT scan as the preliminary modality of investigation. We just need X-ray chest, bloods. Now, we also have, in these COVID positive patients who have come to the hospital, we have 2 more tests to be done to prioritize, in other words, to make sure that are they severe. Now, Dr. Ibrahim, you remember you asked me at the outset, what are the historical factors which tells us who will be doing bad? You remember?
Yeah, yes.
Now I will tell you, we have the lab findings which will tell us who will do bad, and they are D-dimer levels and ferritin levels.
Okay.
So if your patient
routinely, do you do these tests routinely to the COVID?
Yes, it's a trust policy. We do D-dimer and ferritin levels routinely on patients who have earned admission for COVID-19.
How much time does it take for the COVID test to come in your place?
Well, initially, when we also were naive to this infection, it would take around good 3 to 4 days. But nowadays, it's to the tune of 3 to 4 hours only.
Oh, that's wonderful.
As I said clearly, if the patient is at home and has given a distress call based on symptoms, the COVID-19 help team will ascertain those symptoms. They will analyze those symptoms. And if they find that his symptomatology is conforming to seriousness of the disease, they will send an ambulance to this man. And the ambulance will get him to hospital and rest his history. There are other people who also are admitted, would be somebody electively admitted for an orthopedic operation, and then finally found out on the 4th day of operation, they found patient has got fever, he's becoming short of breath, and they do a COVID screen. This patient, if turns positive, he will then get sort of transferred over to the medical side under the COVID ward. Other than that, if you are not a candidate who has a severe disease, you won't be able to come to the hospital because the mechanisms are very clear. If you tell me on the line, if I'm the helpline person and you're the patient and you tell me, sir, I have a fever, I'll tell you how much is it. You tell me, sir, it's 38. I'll tell you anything else. Tell me I have a headache. Okay, take paracetamol. So you take a paracetamol for 1 or 2 days and that's all right. I'll ask you, are you feeling short of breath? No, sir, I'm not feeling short of breath. Stay put. You don't need to come to the hospital. So this is how we ascertain. It's not rocket science. It's like, are you able to cope up with your symptoms? Similarly, if somebody is calling and he is too short of breath to call, we won't let that man talk too much. The phone will be dropped, his line will be ascertained, and he'll be got by an ambulance. So this is all exactly how you come to the hospital and how we ascertain who is who.
Okay. Thank you very much for this elaborate reply. On admission to the hospital, can we prognosticate high-risk cases?
Yes, very good question. When the patient has been admitted, first of all, it's your age of the patient. That is in itself a testament about where you land in. If you're an elderly patient to start with, and you have a multiple comorbidities, i.e. you have hypertension, you have diabetes, you have ischemic heart disease, or you have any other obesity, metabolic syndromes, and more importantly for the COVID infection itself, if you need oxygen to start with, in other words, if you're short of breath to start with, and we found that by putting the pulse oximeter on your finger, and it was known that your oxygen saturations are not normal. Normal, I would say, around from anything from about 95. They are, say, around 92. They are 92 and low. It means you have got hypoxemia. Hypoxemia means low blood oxygen. So when you have low oxygen in the blood, it tells us that more often than not, this patient also will have a concomitant pneumonia. So when we see the X-ray of this patient, we find that pneumonia is there, a consolidation is there, or airspace disease is there. And we also find that he needs oxygen. This is a patient, to start with, a high-risk case.
Okay. Very much. I'm getting a question. What makes elderly people with multiple risk factors more susceptible?
Yeah, they are more susceptible. Okay, fair enough. It's a very good question. What we found in such patients is that if on Monday you did an X-ray chest, it showed a pneumonia on the left side. On the Tuesday, his oxygen requirement went up from 4 liters to 8 liters, and you repeat an X-ray chest, and you find the chest X-ray is now bilateral. On the third day, his oxygen requirement went to 15 liters, and you're going X-ray chest, and it shows a white-out lungs. This is basically a very bad news, and most of these patients did not make it.
Okay. Why there is some difference between northern and southern hemispheres? Is it the temperature, humidity?
Well, all these have been thought about, but they've been blown to the bits. Now, if you take an example of Middle East, is boiling 45 degrees, then your COVID-19 shouldn't have been there at all. I think at this point in time, it's fair to say these are all presumptions and they are not the truth. The truth is that we are not yet at this point in time where we can clearly say, does temperature, humidity, or all those things have any bearing on the infection rate, or how do we get infected by COVID-19? I would say answer is no.
Okay. Dr. Tasaduk, we are getting a lot of trials based on lot many drugs have been tried so far. Do you use hydroxychloroquine or azithromycin or as a prophylaxis?
Well, Mr. Trump was very much, in love with chloroquine, and he almost, wanted it on a point of the knife. Anyway, the truth of the hydroxychloroquine is that its value has been busted out. We are not using it anymore. But I must admit, a month ago, when we had the pinnacle of patients, we had a colossal number of patients, we used this chloroquine as one of the arms in one of our trials. But we now know clearly, it is very clearly now known, hydroxychloroquine, azithromycin, they are not the treatment for COVID-19. In fact, if you give them religiously to patients, they may do more harm than good.
Okay. There was an autopsy series published from Italy. They had shown a lot of patients having thrombotic states, and a lot of trauma were seen before the cytokine storm. Do you use heparin or any anticoagulants in your in sick patients, I mean?
Okay, I'm happy you're a gastroenterologist. Well, the way you know, when you have an inflammatory bowel disease patient who comes in exacerbation, I think the first thing you'd want your junior not to miss is a low molecular weight heparin. True. Similarly, across the trust, across the NHS, it has been made mandatory. I must admit again, it has been made mandatory that all patients who have been admitted to the hospitals with COVID-19 infection kindly start them on low molecular weight heparin.
What about heparin? Because all the problems of economic constraints, can we replace it with heparin?
Well, it does not matter. It doesn't matter which compound you're using, as long as using the prophylaxis. I mean prophylaxis. So you have to give them prophylaxis of heparin. It'll be, is it LMWH or is it simple fractionated heparin? I don't mind. It does not have any meaning.
That's wonderful. So let's come to the next question. Now the patient is sick and is in ICU. First, you tell us what are the precautions the healthcare worker has to take, especially while taking the swab or in the management, one. And second, how do you manage them? Because we have practically seen that no drug virtually acts to combat this virus.
I think if you give me a chance to go back a bit before I embark on your question, that's more important to tell you.
Sure.
I think this will be important for you as well for the future, because you're lagging behind us maybe some weeks or month. Now, we are very much cognizant. We are very much cognizant in our practice that the moment a patient is admitted with COVID-19 to the hospital, we have to ascertain what is the resuscitation status going to be. Let me make it very clear. We give training to all those people who are in charge of COVID patients, be it juniors, seniors, and combating the patients 1:1. Once we have admitted a patient with COVID-19, what we have done beyond what I said, testing, bloods, x-rays, oxygen, and all those things, very importantly, per passive, concomitantly, we also have to talk to the patient, talk to the family, and discuss about, shall we go on resuscitation? We tell the patients, if I have a 90-year-old man, most of my patients are like that age group. If I'm a 90-year-old man who is bedbound for the last 2 years, has 3 to 4 carers coming to his home every day, is very hard of hearing, is very deaf, quality of life is absolutely compromised, and he comes to me with COVID-19 infection, and he does not have capacity. He doesn't have a mental capacity to tell me he wants resuscitation or not. We call the family very fast because we know time is not on the side. We call the family. Most often than not, the family may not come. They will talk on the phone. We talk to the next of the kin of the family of this patient and tell them clearly, listen, we explain them like this. We tell them, worldwide, we have seen people who have been put a tube inside, in other words, ventilated. They have done extremely poorly. Some series say 80% mortality, some say 90% mortality. We tell them, this patient of yours is already 90 plus, his quality of life is poor. What do you want us to do in his chest if he stops his heartbeat or if he stops to breathe at a time? Most often than not, they are very understanding. They will say, no, nothing like that. So we clearly write on the patient's file, we put in the system, we make it understand in the system that the documentation would be, this patient, COVID-19, Mr. X, age this, with this comorbidities, had a family discussion, and he will have a do not resuscitation status as positive. The family was on the board, the patient did not have capacity, and the next of the kin was on the board, and this sister was in charge, and these 2 doctors have been at that time. That would automatically mean if this patient has problems on the ward, he won't be escalated from the ward onwards. Now, on the contrary, if I have another patient now who is 70 years of age, was doing fine before, has been fit, has been doing a morning walk every day, 4 miles, but has got 8 to 10 comorbidities with him, other medical conditions. Again, we will not want to get these patients intubated and ventilated. We'll escalate them to level 2, and level 2 would mean either a coronary care unit or high dependency, we call it HDU. And there we give them NIV, either a CPAP or a BiPAP.
Oh, that's wonderful. We're getting another question from our surgical colleague, Professor Omar Shah. He says that what surgical procedures are worth reporting during COVID pandemic at your place? What surgical procedures were worth reporting Well, he probably means, Dr. Shah, do you mean that which patients you operated upon? What surgical procedures were worth reporting during COVID pandemic at your place? This is the question.
Professor Shah
Yeah.
is a friend of mine, and I know his questions can never be very simple. So let me come to exactly what he wants to say, possibly. I think the procedures which are always emergent procedures, you can never stop them, be it COVID-19 or be it anything else. So I would say patients who had come in emergency laparotomy stemming from obstruction of the colon, colonic cancers, and mainly orthopedic surgery. Like somebody had an RTAs and this happened before, or somebody is frail, had a fall, and has dislocated a hip and all those things. So otherwise, I must say, surgeons in our place also have become COVID-19 warriors.
Oh, so taking up to the next question, what about the remdesivir? Do you believe it has still any role?
You see,
there has been a conflicting data. Some supports.
Yeah. If you see, remember one thing. I think I'll tell you something very clearly. When we have nothing in hand, and when we know that there's nothing going to be in hand in the near future, then you want to. It's like a drowning man catches at a straw. You want to hold on something.
Exactly.
Now Tony Fauci, who is the guy, who's the leading guy, and the author of Harrison's internal medicine book, he's a reputed guy. He found some positive in this remdesivir, and what he found was that the 5-day course was equal to 10-day course, and they found that there was a speedy recovery in those patients who were given this medicine, and the speedy recovery was of the tone of, if it took 11 days for a person who took this medicine, it would take around 15 days for the person who did not take it. So it was around 31% of the speed, increasing the speed. The second thing was that when it came to the mortality decline, I think it was a bare 3%, 3.5% decline in mortality, which was statistically not significant. However, there's a point here, which Dr. Tony Fauci as well has said. He said this data at this minute has to be propagated on more and more patients, and if by any chance we could decelerate or get down the infectivity of COVID and make sure that we can somehow get down the reproduction auto factor, then we might get the pandemic on its head until we have something like a vaccine. But the real panacea will be once we will have a vaccination done for COVID-19. Until there's a vaccine, I can tell you there won't be anything really, affirmative about treating patients of COVID-19.
Thank you very much, Dr. We have seen world over a lot of healthcare workers died because of COVID. A lot of surgeons, a lot of physicians, a lot of nurses. We lost so many in this battle. Can we draw lines? What were the possibilities which they could take and just save themselves from this COVID infection?
I think out of all the questions you've asked me thus far, this is the gem of the question, because one of my registrars as well, we lost him as well in this battle for COVID-19. Now your answer will be given by a very important study. It was done in the US, and the study found very clearly, it's a very interesting study for all of us to understand what is basically going on. The study found that in other words, the least mortality of the health workers, it happened in the ICU, intensive care units. This is looking like what am I talking about? Am I confusing you? I'm not confusing you. The only reason is, again, common sense. When you are in the ICU, as a default, you all take precautions. You take all the real precautions, i.e., you wear the respirator, you wear the mask, you wear the eye shades, and you wear the dumper, and you wear the gloves, and you never lower your guard on ICU. In NHS, the initial mortality which happened, it happened in the GPs, the general practitioners. because for them, they did not know what COVID-19 was. And also, mind you, why COVID-19 is a very notorious disease is that you could be absolutely normal, but shedding a lot of viruses, and nobody else will know that. And you are giving this virus to a susceptible patient, and when he gets it, he dies, but you have no problems on your own. So this happened in the NHS in the initial term, that people possibly were complacent with the masks and with the PPE, and possibly the PPE, which was not donned in a proper way, did do the trick. So I must reiterate, there's nothing like COVID suspect, there's nothing like COVID positive. If a patient comes to you with symptoms which are suggestive of COVID, please take them as positive. And if the patient is in an area where you are generating aerosols, you're generating millions of droplets, i.e. patient is on nebulizer, patient is on NIV, a BiPAP, a CPAP, tracheostomy, ENT surgeries, all those things, kindly do not wear a surgical mask, but wear a proper PPE2 or N95 in addition to anything else.
Oh, that's nice. So let's come to the sick area patient, because the most vulnerable red zone is the sick ICU patients. On ventilator, are there any differences in tackling COVID-19 induced ARDS from usual ARDS? What are the options if the patient does not seem to work? And when do you intubate a patient?
Okay, that's a very important question. But before I answer this question, because otherwise I will forget the finale which leads to the ICU admission, I must first of all a bit backtrack, if you allow me.
Yeah, sure.
When the patient is on the ward, has been given oxygen, and oxygen requirements are just going up in a linear manner, 4 liters, 8 liters, 12 liters, 50 liters, 15 liters, and still your patient is not doing fine, we then escalate this patient to basically non-invasive ventilation. We put them on a CPAP. The only reason we put a patient on BiPAP is if we have a patient who has a prior COPD, or we are contemplating that the patient will have a type 2 respiratory failure in treatment. Otherwise, it's a CPAP. Now, NHS Trust has a guidelines for our CPAP. We have a guidance. We don't start with a very high PEEP. We start with PEEP of 5 and say FI2 of 50, 60, and go up like that. So we then start stabilizing these patients on a NIV, on a CPAP. Now, it's very important, Dr. Ibrahim, to know here that all the studies have clearly shown if you are able to get the patient max on the CPAP or BiPAP, and you don't want him to go to the ventilator, you are basically it's a tug of war. You're pulling him away from death. If you are not able on the CPAP to get a patient salvaged enough to go to the ventilator, it's a bad news in itself. So I've answered you. I've answered a question which you have not asked me. Who are the patients who go to the ventilator? Those are the patients who go to ventilator who have not been able to take oxygen on the wards, who have not been able to be rectified with the CPAP, despite up titration of oxygen and PEEP, and then you are left with nothing but you'll have to intubate and ventilate. And also, I must admit, it was clearly shown in the studies in NEGM that patients who were male, gender, elderly, had diabetes, they were more often than not ventilated if they were poorly than those who were not. Also remember, very important to point to ponder upon, if you have a constellation of diabetes, hypertension, and ischemic heart disease, the 3 in combo had the risk factors worse than a chronic lung disease. Are you getting my point?
Yeah.
So the 3 risk factors are worse than having a COPD, if you will. So when you have got these patients on the oxygen, they have failed, on the CPAP, they have failed, you're left with no option than to ventilate. Yes, what are the readings, what are the settings we do and what we do on ventilator? This was your question, basically.
Yeah.
Now, I'm sure there must be some interventional as well as some ICU.
We do have.
So primarily we prefer basically putting them on a low tidal volume. When I say low tidal volume, it be in the range of 4 to 8 ml per kilogram of the presumed body weight. So we want tidal volume to be less than 8 ml in any case. The second thing is we favor high PEEP than low PEEP. And I'll do the answer later on. And when we have given in a high PEEP, i.e. more than 10 to start with, on a ventilator, it's not a CPAP, I was saying 5 we start with, it's a ventilator. On a ventilator, we start with a high PEEP, then low PEEP. I would mean anything about 10 and above 10. When a patient is on a high PEEP 10 and above, we should also be wary about what we call is a barotrauma. They may have a pneumothorax coming due to the high PEEP. And that's why we'll have to get the X-rays often done.
Mm-hmm.
And also, we prefer judicious fluids. We don't want to give them a lot of fluids. We are a bit stringent on the fluids in these patients. And very importantly, I did tell you at the start, we do a D-dimer, remember?
Yeah, sure. D-dimer.
Yes. Now, if I have a patient whose D-dimer was very high to start with, and now is ventilated, this patient would have in between got a CT scan for a spiral CT scan or a CTPA to rule out associated pulmonary embolism. We also found there was a higher incidence of pulmonary embolism with COVID-19 patients ARDS. Now, again, not really central pulmonary embolisms, mostly subsegmental and segmental pulmonary embolisms, but they did have it in combo. So if a patient has a very high D-dimer, we'll do a CTPA to ascertain, does this patient have pulmonary embolism? If this patient now is on the ventilator, definitely he'll be on the treatment dose of therapeutic heparin or low molecular weight heparin. Also, what we do on these patients is that we, as I said, we are very much, we don't give them too much of fluids. Now, coming to these muscular, relaxants, we prefer not to give them a continuous infusion of neuromuscular blockade. We give them as and when they need it. The only condition, we have to give them continuous boluses of neuromuscular blockade would be if they have a constant ventilator dysynchrony, if we want sedation on the patient, and if this patient has a high plateau pressure, and if the patient is not able to tolerate the prone ventilation. And very importantly now, very important point is that all the COVID patients who have been on CPAP or who have been on a ventilator, we try to prone them 12 to 16 hours per day to help their oxygenation. FiO2 goes up.
Oh,
am I online still?
Yeah, sure. You're on the line where everybody's, I think, enjoying your talk. Thank you so much for being so elaborate in this thing. Just one thing, that acute coronary syndromes are getting missed in severe COVID. How do you take it? Do you do routine ECGs? Do you do troponins routinely? Of course, we start them antithrombolytic therapies, low molecular weight heparin. Do you start routinely aspirin? Do you routinely start antistatins and other drugs to be sure that before the house is on fire, we'll start things before that?
I think it's a very important question. This question basically tells us about what are the intricacies, what are the difficulties we people have when we are treating patients with COVID-19. The whole world is frenzied with COVID-19. We have COVID-19 on our mind. We dream of COVID-19. Whatever we touch, we see COVID-19. And then what happens is that hello sir, how are you? Somebody's having biscuits and he's watching my program. I'm loving it, no worries. So, okay. So what happens is that when these patients, hello, I'm online, please.
Yeah, you're in line. Yes.
Okay. So
we're listening. Everybody's listening.
The most important intricacies which we have with this pandemic is that we should have basically a very fine line, a delicate line of not missing the routine illnesses, which will be there. You will still have myocardial infarctions happening at the same rate, perhaps more than previous because of stress. You'll still have strokes. You'll still have appendicitis coming up. You'll still have cancers. So I think I would use the word, we have to use our wide angle glasses. We are physicians at the end of the day. And when we find, for example, I'll give you an example about a patient who is as old as 2 weeks into in my hospital. This was a 46-year-old lady who was a COVID suspect, and she had come with history of shortness of breath and a bit of a fever, which was not documented, and she had a dry cough, which was absolutely not much. While she was it was those days when the COVID test would take around 2 to 3 days. So her COVID was still awaited. And what happened was that when I was rounding this patient with all my gears and PPEs, and in the midst of those gears, I found that her oxygen was plummeting. Her saturation was around 85% on 4 liters. And when I had a look of the X-ray chest, it was normal. There was no pneumonia. So as I said, we are clinicians at the end of the day. We are basically doctors who have been doing everything. So some sort of everything. So this is a lady who is not positive yet, or whose test is not come yet, is suspect, does not have a fever, has a shortness of breath. X-ray chest is not explaining me the shortness of breath. There's no pneumonia if it was COVID, but she is significantly hypoxic. And ABG shows a wide AO2 gradient. We do a D-dimer, and D-dimer in our lab normally is less than 250 is normal. It came out more than 1,000. We went for a CTPA, and she had a classical bilateral pulmonary embolism not related to COVID-19. So are you ascertaining, Dr. Ibrahim?
Yes, sir. Yeah, we are listening.
So in other words, you are picking up a natural patient who could have been basically killed by the fear of COVID-19 in the doctors, not to speak of the other people. So had we just seen her from the prism of COVID-19, we definitely would have missed this PE. And time is the muscle in any sort of emergency. She was started on treatment appropriately, and 3rd day she went home and she was COVID-19 negative.
Yeah, Professor Prabha Adhikari is saying that this is a good message, that we have to be good physicians and not specialists. Keep our eyes open in a good message.
Absolutely. So, I always tell my juniors, we have to be acute physicians. Unless and until in medicine 2 and 2 is 4, you have to understand something is missing somewhere. And if that something is accounted for by any test, it's valuable, it's worth it, and you will not miss a patient.
Yeah, what about the cytokine storm? Any role of steroids?
Well, I must tell you, it's my practical experience with 3 of the patients on the ITU where I was involved, because normally our ITU is basically a closed ITU. In other words, once the patient comes on for ventilation with a COVID-19, normally they don't ask us much because there's an interventionist there who is basically a respirologist as well, and they're anesthetists, and they are very much trained enough. It's only sometimes they ask as a respiratory physician, they ask you something more, which they in their need for some reason. I found in all the 3 patients who were on ventilator, we gave them a good dose of dexamethasone, and later on changed to methylprednisolone as per the Wade and Shaw in Manchester. They did some studies. And I'm regretfully telling you, we lost all the 3 patients. So in that series of 3 patients, methylprednisolone, a good dose, it did not work. And now I can tell you, with all the studies I have, prednisolone has not helped patients with COVID-19.
Okay, that's a wonderful. Dr. Tasaduk, till the vaccine is in the market, we have the only way is that we have to rely on the masks. We have to rely on the N95 masks, about the PPs. Could you elaborate upon this, about the oral factor and what N95 for our students who have joined in this, and what kind of PPE would you recommend at different levels of patient care? We will not say PPE at every level.
All right, fair enough. Now you have to remember one thing. You'll be surprised. In the UK, you will not find people wearing masks in the open. We are still under lockdown, but we do come out with what we call as a physical distancing. We don't call it a social distancing. It looks very crude to call it social distancing. We use the word physical distancing. Our markets are open. I'm not saying all the markets, it's only the central markets are open. We have a queue there, but we all maintain a distance. So they will make sure that half of the people are coming in only when the half of the people have gone out. So it's, in other words, it's monitored the way you enter a mall. You see, at the end of the day, I have to have my bread, I have to have my tea, I have to have my food to live. I will live, then only the problem of COVID will start. If I'm not living in the first place, then this is very immaterial. Now, coming to the masks, what NHS believes is that when you wear a mask, basically the only role of your mask is that if you are suspected, if you have an infection possibly, you don't want it to carry to other person in the society. However, if you are having problems, which you said and which we clearly defined, I will ask the patient to quarantine and self-quarantine 7 days and all those. I've said it before. Now your question is N95. The word N stands for not resistant to oil. So your mask, which is N95, it is not oil resistant. And 95 means I'm giving you the guarantee. The manufacturer is giving you the guarantee, or the respirator is giving you the guarantee that if you wear this mask, you will not have 95% of the particles less than 0.3 microns won't enter you, won't enter your mouth or your nares or your nose. That's N95. Now, let me tell you what we do in the NHS. In the NHS, as a doctor or as a nurse or as a healthcare provider, if we are in a COVID positive bay, but we are not using any method which can elaborate or which can generate aerosols, we will use a simple surgical mask. We will not even cover our eyes if there is no aerosol, but you are allowed to do so, and you will have a gown and you will have a gloves. If the same person enters, of course, and then when you see the patient, when you see the bay, within the bay, in that cubicle, in that room, you will have to take off, you have to doff all what you have worn, where the last thing which you will come out will be the mask, and you will have to drop it in the other bin. However, when you enter a COVID positive bay, wherein a patient is on a CPAP or a BiPAP, or patient is being nebulized, and you know now that the patient will be generating a lot of aerosol, a lot of air in the droplets will be in the atmosphere, then by default, this doctor or healthcare provider will have to wear N95, FFP2 or 3 respirator, and all the same, and gloves, plus definitely eye shade as well as the solder.
Okay. Coming back to this, we'll carry on this thread. So how do doctors work there in COVID hospitals? Is it 1 week with 6-hour duty, or 2 weeks off, and then quarantine? I mean, just what's your rota? How do you manage it?
Well, you'll be surprised. Despite of so many deaths happen in the UK, I can assure you one thing. The last thing we have here is panic. We are living a very natural life. That is very important to know. I mean, if I were to take the laptop and show you on the left side, this is a street here, you'll see the cars are there, but people here are definitely, we have to be responsible. If I have symptoms, I'm definitely not going to be on the road. This is for sure. Now, if you in your place can make sure that the people can inculcate and can show the maturity enough to tell you that I'm not well, I will self-quarantine myself in the place, then definitely we will not be as, I would say, stringently locked down as the way we have been. And it's very important to tell you, Dr. Ibrahim, also, the studies have clearly come up now after the first infection happened in Wuhan until now. People in this self-isolation have been more cases of depression.
Yeah.
And you should remember, when you are isolated, you get depressed, you do not socialize, and the chances of stress getting more of mental infection are there, chance of getting infections are there. And again, by dint of the same corollary, if you get COVID-19, you will not fare as good as if you're not depressed. So I think we have to develop some mechanisms whereby we have to somehow find out ways that we live life near normal. Of course, it can't be normal anywhere in the world. We're not traveling anywhere. But we should not feel a gag. We should not feel that we have been locked down. Our lives have been caged. I think that's not going to solve the issue. Back in my place in Kashmir, they are calling those zones red zones, green zones, and what zones, I don't know. But you must have seen, despite the full lockdown, you still have positives. It's everywhere. It's a pandemic. Don't be surprised with the positives. Positives does not mean anything. If we systematically screen all the world, I think by September, 70% of the world will be positive. And that will tell you 4 billion people have already survived. So we have to be optimistic about what's going on. I will reiterate, only 3 to 5% patients will have mortality. Now, if you tell me, if you impress me, oh, no, in Italy, the mortality was high, the answer is they were not screening at a time, not many people. I'll give you an example. Are you with me, sir?
Yeah, sure, sir.
I'll give you an example. What is the case fatality rate and infection fatality rate? This is very important for all of us to understand this example. Now, if I have 100 people in my area, if 100 people in my area are having COVID positive, but only 10 people are sick enough to come to the hospital and they have been tested positive. Now, in these 10 people, if one patient dies, so what is the CFR? What is the case fatality rate? 10%, correct?
Yeah, correct.
In 10 people, if one patient dies, it's a 10% mortality. But imagine the 99 people, they did not die. The infection mortality is only 1%. So this is exactly how people have found a difference. So I must say, it's not a huge mortality, but the best way to counter is we have to follow the government rules, but at the same time, there has to be a balance between living normally and living under lockdown.
Okay. There are a lot of questions coming. I just wanted to know what are the UK quarantine policies compared to the India and compared to the UK. How do you compare the two?
All right. Do not interrupt me. I'll tell you exactly the algorithm. I'm a patient. I'm calling the helpline. You're the helpline. I'm telling you, sir, I have a fever for 2 days. I have also headache. And the answer from you is coming to me, stay at your home. Stay for 7 days after you have felt well. Now, I'm feeling okay after 7 days, but at 7-day time, I have a fever. I again call you, sir, today is my 8th day. I have called you 7 days ago. My fever is still there. You know what the answer coming from the helpline? Stay at your place until you are completely without fever, until you are afebrile. And when that happens, automatic. I think there's somebody is opening the video. There's a lot of noise coming. I can see a guy coming and coming. I'm sorry to say that, but I mean, it's distracting me a lot. If you could get rid of this thing.
Yeah, I request all participants kindly put off their mics and videos.
As long as he was having a bread, I didn't mind, but now he's listening to the music, you know. Anyway, so what I'm saying is that when this patient has had no fever, he is not meant to be in self-quarantine. Now, if this patient tells me at 10 days later, tells the helpline, I have a cough now, no fever, I'm better, but I have a cough. Now, remember, as per the NHS guidelines, cough will not keep you in the quarantine. We know that COVID-19 you could be healed of COVID-19 and your cough can stay for weeks. So if I'm asking you, if I have a cough, does it mean my quarantine will extend? The answer is no. I will again repeat for all of you. If I have recovered at my home 7 days post symptoms, I have been fine, excepting my cough. Shall my cough keep me in the quarantine? The answer is no. Now, this is a person who's alone. Now, if I'm a person and I'm living with family, and this more often happens in our place. So I have symptoms. I've called the helpline. The helpline has told me to stay in the hospital at my place for 7 days after my symptoms have settled. But they have told my family to stay at my place for 2 weeks. 2 weeks from the day I got the infection, I got the symptoms. Are you with me?
Yeah, sure.
So if I got the symptoms to start with, and I was told to stay 1 week after my symptoms are gone, my family was told same day, the day I started with symptoms, to stay for 2 weeks. Within these 2 weeks, if none of anyone of us, excluding me, shows symptoms, the whole family is deemed as negative. We don't screen them any further. They were not screened to start with. They won't be screened later on.
Okay. What is the discharge policy in your hospital?
If I have a COVID positive,
how do you plan their discharge?
no worries. So you're asking me what are the policies of the NHS policies of discharging the patients?
Yeah, because the problem is the person becomes positive, then becomes negative, then a
No.
negative person becomes positive. So
Very simple. As I said, if you are a key worker, which I defined in the start, I'm not repeating it again. If you're a key worker and you had COVID positive infection, trust me, we do not even swab them again to become negative before they come to the hospital. I had almost around 30 to 40 patients, colleagues of mine, who took one way or the other 2 weeks off because they were not well. They were told to stay back at home for 2 weeks, and they came back home. They came back to the work. They're working with me. They're fine. I'm fine. So you have to understand one thing. If you, as a patient, come to the hospital and you have been proved to be COVID positive and you did not have a pneumonia, your saturations of oxygen were excellent, you were kept for 24 hours, and second day you had no fever, your bloods are near normal, we are discharging such patients. They go home and stay at home for around 1 week quarantine from the time they feel better to 1 week. And the family will be in quarantine for 2 weeks from the first day this patient had symptoms. I can assure you, we have discharged from the ward patients whose test even did not come back, but they were fine. We send them back home. We have no quarantine centers. Please remember, UK does not believe in quarantine centers. We believe the best quarantine is your home. Now, if you ask me, at your place, you have a very important elderly patient who has a lot of vulnerabilities, very elderly patient, high-risk patient, then what we do in such patient is that, yes, you have care homes. We could facilitate this elderly patient's departure from that home to either a friend's place, friend's home, who have less people there, or to a care home. Otherwise, if you're healthy and fit, even if the whole family is having symptoms, they will all be quarantined at their place for 2 weeks. And should someone in the family who are in quarantine within the 2 weeks' time develop symptoms, he will also go through the same cycle of staying inside for 7 more days. But the quarantine of those people will not end. 2 weeks, that's it. Recently, as recent as 2 days ago, we were asked to do a check test for a quarantine, for a positive COVID patient on the ward. We're told we need 1 negative for this patient before this patient goes to care home. This was the first time in a battle between us and COVID-19. This situation arose first time in the last, I would say, a month plus, that we had to do a check test to say patient has become negative before he go to the elderly care home. But going back to home, we don't do any screening further.
Oh, that's very nice. Dr. Tasaduk, there have been so many drugs have been tried. One of them was ivermectin. Famotidine has come. I don't know how far this fancy struggle will continue till we get a real answer. What's your take on this?
See, as I said, when you don't have anything to do, you try to keep yourself busy. And one of the best ways to be busy is to play with these drugs. We call it yo-yo. Go back, go front, 1 step forward, 2 steps backward. Now, if you understand from the mentality or the psychology of the drug remdesivir was, as per the Chinese study, it had failed. But the same study was conducted in the US, and it was made to sort of pass. But is it a panacea? Is it the answer? The answer is no, it's still experimental. Mind you, remdesivir is still experimental. It has been used on a compassionate basis. FDA has been bypassed. But is it a drug? You will give it to all patients. If you're using it right now, you're using it frantically. But are you using it rationally? The answer is there is no rationale as yet. A lot of studies have to be done. A lot more blood has to flow before people will succumb, and then you will say this drug was doing wonder. I think at this point in time, I would say it's
Yeah,
too early
true.
to say we got a medicine.
True. There are a lot of questions are coming. What about this? I'm just screening the questions. Do you feel that BCG in India has played some role?
Well, this theory had been initially taken up, but as per the WHO series now, I would say no, it does not have any protection. It does not have any protection.
What's the reason that we have more fatalities in the Western world compared to India?
Well, I wish we stay the way we are.
Yeah.
But the problem is we have to understand one thing. This is the same virus. And also it's very clear now from all the studies, including the WHO, it has not mutated much after it has left Wuhan. So it jumped from bat to man, and from man to man, and from one continent to another continent, and became a pandemic. But we can, at this point in time, clearly say, very clearly say, has it mutated? The answer is no. It has not mutated enough to be called, oh, it's highly mutating. No. But in this, so why I'm building this premise? I'm building this premise to tell you is that it has its own tail, which it has given in all other places where it has been. So I think it's a matter of time. We may be behind time, but the virus is same virus which has caused havoc in a place in the West. Now, we in India have one silver lining which no one can take away from, is that we in India are a young nation. That may be something. If we get even 80% patients are positive, they will not have any mortality. 15% will also have problems. They will not have mortality. So it comes back down to 3 to 5% mortality. That will also be a big mortality. But if you are basically by the lockdown, you are protecting your elderly ones at home, then it will definitely come down. The mortality will come down. So if anything is on the side of Indian nation, it is India is relatively a young country. The Western countries are not young. It's sort of I would say it's a knee-jerk response from me. I'm not a scientist at all, so I can be blown into bits in my emotion, and I'm usually wrong. So don't take me very seriously.
So how do you, this is a very nice session going on, and I'm getting a lot of messages that everybody is enjoying your expertise and the way you are explaining. Highly grateful to you. And any psychological aspects of this infection, isolation, there is a lot of psychological aspects in the healthcare workers also, because we saw a lot of people dying. So how do you summarize it?
You see, we in the NHS, we have the leaflets. We give the leaflets to the patient when they leave home. We have to understand one thing. The world is a global village. We are connected by the internet, by the social media. This is the time we could go back to our hobbies. I know in India, as myself, we are used to these Bollywood movies, Tamil movies, and different, this music and others. This is the time to build up your piano, sessions. It's a time to learn your guitar. It's a time to learn your,
Wonderful.
If you're a story writer, go and read more books. If you want to learn the grammar, go, and this is the time to learn grammar. If you want to pick up a language, it's the time to pick up language. So don't feel
good.
Take it as an holiday which you will never get again in life.
True. So what I could get from you that beyond this, just a good resuscitation in the ICU, one, and prophylactic low molecular weight heparin, and antibiotics, that should all go.
Prone position.
The prone position. There was one paper had come in the prone position also.
Yes.
Yeah.
We, as I said, once the patients who need oxygen and they're on the NIV, I mean PEEP, if they're on the CPAP or on the ventilator, we tend to keep them prone for 12 to 16 hours per day. Not everybody will tolerate that much, but more they tolerate in a prone position, better their oxygenation is. And the last point I have not touched, and I think it will be fair enough to go without touching that, I have to say that, is that if we have done all in our capacity on the ventilator, we have done proning, we have played with the plateaus, we have played with the recruitments, we have played with the fluids, we have played with the antibiotics, were played with the anticoagulants, and still the patient has got a refractory respiratory failure despite being on all you've done, then in selected patients, we do Ecmo, which is basically extracorporeal membrane oxygenation. We have certain centers, and again, the bad news is that COVID-19 ARDS, when they are very much advanced and to the level that you have put them to ECMO, some patients did make it, but dismal proportion have been the fate of the ARDS, which the COVID patients do have. So the message is that if we are able to keep the patients off ventilator, we have a chance. The moment the patients are on ventilator, it's difficult to get them back. Very, very difficult. Although people will now say, there have been theories, series that say 60%, but in our hospital, our mortality was close to 88.2%. So it's a very dismal mortality still. COVID ARDS is a bad news.
Dr. Khan,
Yes, sir.
I was very fascinated by your clarity of your expression.
Thank you very much. I'm humbled.
It was really worth watching you and listening to you, and probably we have become a little more wiser.
Well,
and
thanks
the
a lot.
way how you treat your patients, as well as the clarity of your thinking as to who should be again investigated for COVID, and when is there any necessity for a second COVID testing? I think in India we still do the second testing. We cannot help that because the government laws say that. And I think in NHS, I think you have a very clear regulation. I think you follow it very clearly. I think
Yes.
that's where the success comes from. Anyway, it was wonderful. Thank you very much for spending a lot of time with us. We enjoyed it. Thank you.
Thank you very much. My pleasure too, sir.